we are on stage now.
Okay, we'll wait till 11 o'clock.
Okay. And we are live.
Okay. Hello. Good morning, colleagues. Let us start our next session, which is on training and outcomes in coronary artery bypass graft surgery. My co-chair today is Shahzad Raza from Hayfield Hospital, and very soon we'll also be joined by our other chairs, Torsten Donst from Germany and Sigrid Sandner from Austria, and I'm Vipin Zamba from Edinburgh. So let's start now. Our first speaker is Jason Ali from Papworth Hospital, and he's going to talk on early postoperative bleeding. Jason?
Thank you for the opportunity to speak. I would like to present our work, aiming to look at the impact of volume of postoperative bleeding on long-term survival following coronary artery bypass grafting. It is well recognized that postoperative bleeding is a complication following cardiac surgery that is associated with significant morbidity and mortality. Patients who bleed require blood transfusion and re-exploration, and each of these has additionally been associated with inferior outcomes following cardiac surgery. The aim of this work is to examine the impact of the volume of early postoperative bleeding on long-term survival for patients undergoing coronary artery bypass grafting. We examined all patients undergoing CABG between January 2003 and April 2013 in order to have a long period of follow-up. We included all first-time CABG times 2 or more performed on pump with 30-day conditional survival. We opted to use 30-day conditional survival to exclude those patients who suffered such significant complication within the perioperative period to succumb, and in that way, aiming to examine the impact of bleeding on those patients who survived the perioperative period. We categorized patients into 3 groups in terms of volume of 12-hour blood loss: less than 500, 500 to 1,000, and more than 1,000 milliliters. And we performed long-term survival and multivariate analyses. Over the period of study, 6,270 patients underwent surgery with a mean age of 67.8 years, mean logistic Euro score 4.9%, and our follow-up median was 11.5 years. 4.6% of patients were re-explored, and 43.6% of patients received at least 1 red cell transfusion. You can see in the table that the majority of patients experienced less than 500 mL of blood loss within the first 12 hours. However, there are a significant number of patients who experienced more. We first performed a multivariate analysis looking to identify impact factors that are independently associated with long-term survival in this cohort. And you can see the list of factors on the slide. As you would predict, factors associated with inferior outcomes, such as age, smoking, presence of other comorbidities. But importantly, we found that the volume of blood loss was independently associated with inferior survival in this cohort, and more so for those experiencing the greater blood loss. Interestingly, re-exploration and receiving blood transfusion themselves were not independent predictors of inferior long-term survival in this cohort. This Kaplan-Meier curve demonstrates the separation in survival curves, highlighting the significantly inferior survival for those patients experiencing greater than 500 mL of blood loss within the first 12 hours. We also looked to identify factors associated with higher amounts of bleeding. And again, factors that you may expect, for example, the urgency of surgery, perhaps related to the use of antiplatelets, duration of cardiopulmonary bypass, number of bypass grafts, amongst others. But interestingly, there was no association between the volume of 12-hour blood loss and the incidence of re-exploration or the administration of blood transfusions, although there was a trend. In this study, we have utilized a large cohort of patients with 30-day conditional survival and a long follow-up period to examine the impact of bleeding on long-term survival. We used 30-day conditional survival to exclude those patients who suffered severe early complications. And although we see that there's no apparent association between volume of bleeding and re-exploration of blood transfusion, we believe that this is related to the imposition of 30-day conditional survival, as this therefore excludes those patients who experienced such significant bleeding and required re-exploration or substantial blood transfusion, but who then died. What we also found is that 12-hour blood loss is associated with increased incidence of other complications such as renal failure and stroke. So in conclusion, we've been able to demonstrate using this large number of patients that the volume of 12-hour post-operative blood loss is an independent predictor of inferior long-term survival following coronary artery bypass grafting. And this emphasizes the importance of intraoperative hemostasis and strategies aimed to minimize post-operative bleeding, such as the use of a hemostasis checklist. Thank you.
Thank you, Jason. That was a very good presentation. Now, Shahzad Raza will be looking at audience questions. But while we get the audience questions, can I ask you, you looked at all patients who had on-pump coronary artery surgery. Was there any reason you excluded the off-pump patients? Is Jason here?
Looks like he's not.
He's not here. Okay. Okay. In that case, I think we should just move on to the next presentation.
Yeah, and also I think we should encourage the audience to rate the presentations.
Yes,
that'll be helpful as well.
Okay, so for all the audience, if you go on to the tabs, there's one tab for question and answers. Please ask questions that will lead to a good discussion here. And also the next tab is polls. So after every presentation, just please rate all the presentations. That will be good feedback for the speakers. And our next speaker is Manish Soni from Hayfield Hospital, and he'll be talking about trainee perceptions of off-pump coronary artery bypass graft surgery. Manish?
Good morning, everyone. I am Manish Soni, and I'm presenting UK OPCAB Training Needs Survey, trainee perceptions of off-pump coronary artery bypass grafting. First of all, I would like to thank Society of Cardiothoracic Surgery for giving us the opportunity to present this survey, and kudos for all their effort to make this happen despite the challenges. Off-pump coronary artery bypass grafting, that is OPCAB, is an established strategy to treat high-risk patients referred for surgical myocardial revascularization. Progressively, increasing number of high-risk patients are being referred for coronary artery bypass grafting. Cardiac surgical trainees of today will be confronted with this high-risk cohort of patients in the ensuing years. Hence, it's logical for them to get training in this innovative approach. We conducted a survey to understand the perceptions of cardiothoracic trainee surgeons in UK and Ireland regarding OPCAB, as well as their interest in potential training to achieve competence in this skill. An online survey questionnaire comprising of 10 questions was sent to all the cardiothoracic surgery national trainees, which are 118 in number, at 14 training program in UK and Ireland. The questionnaire was generated using the Google Forms platform, and the responses were tabulated and analyzed. The first question was, what is your training year? The maximum response came from ST8, that is 24.6%, and ST1 responded 3.5%, and the rest were in between. Which is your region of training? London, having the maximum trainees, participated most, 30.8%. Are any consultant cardiac surgeons in your training program performing OPCAB? And we can see that nearly 52% responded that less than 25% of surgeons were performing OPCAB. And 1.7% said that 100% of consultants were doing OPCAB in their centers. Is there formal training in OPCAB in your training program? 75.4% said no. Do trainees perform OPCAB in your training program? And we can see that 60.3% of the participants said no. Are trainees encouraged to train in OPCAB in your training program? Again, 67% said no to the encouragement received for training in OPCAB. Do you think OPCAB is an effective surgical strategy? And yes, nearly 88% approved of this. Do you think training in OPCAB will be beneficial for you in your future clinical practice? Again, nearly 90% said yes. Will you be interested in out-of-program training in OPCAB? We can see that 70.7% showed interest and 56.1% were keen to do post-CCT fellowship in OPCAB. The result of the survey suggests that majority of the cardiothoracic trainee in UK and Ireland perceive proficiency in OPCAB as beneficial for their future clinical practice. However, training in OPCAB is variable across the training programs, and there is a need for structured training. Learning curve of OPCAB is an important issue that precludes universal training. Introduction of a surgical training tool which is specific to OPCAB, like use of virtual reality simulators, structured intraoperative training, direct supervision of competent mentors, and careful selection of cases are some of the interventions that can enable the trainees to imbibe this technique with minimal anxiety and stress without jeopardizing the outcome or patient safety. So were there any limitation of this survey? Well, we had to email the survey twice to maximize the response rate, yet 25% of the invited trainees did not participate in survey. Hence, one of the major criticisms of the study is the issue of non-response bias, which makes the conclusion questionable. Another major limitation of the study is acquiescence bias, and this happens when question is posed with unbalanced answers like agree, disagree, or yes and no. It is a common form of measurement error in surveys, and when this happens, it has substantial effect. Furthermore, answers were not verified for accuracy, which is another recognized drawback of online surveys. Despite all the aforementioned limitation, this is the first ever survey that provides information about trainee perception of off-pump coronary artery bypass grafting in United Kingdom. Thank you very much.
Thank you, Manish. That was a very good presentation. I suppose that's a very poor reflection of off-pump Cabg surgical training in the UK. And I see John Puskas has logged in as well. Hello, John.
Good morning or afternoon.
Good morning.
It's still morning in the UK. Shahzad, are there any questions from the audience?
No questions yet.
Okay. Can I ask you, so this survey, how many trainees are there in the UK? To how many trainees?
Yeah, good morning, everybody. Good morning, Mr. Jamlar. So there are 118 trainees in the program all over. And this survey was actually aimed at the trainees, so not for all the registrars. And what was surprising is, although many of them have not even seen off-pump surgery, but they were aware that there is a need for this skill. And as you can see from the survey, nearly 90% approved that yes, if given a chance, they would like to train in future.
Are there any formal training programs after graduation and qualification in cardiothoracic surgery to augment a resident or fellow's skill in OPCAB? Are there recognized or advertised specialty training opportunities a year with Dr. Tagret or some such thing, or Dr. Zambar?
There's first of all interest of the trainee, first of all, and then what I did, it was an informal training with Mr. Raja. I chose that center because I knew that center was nearly doing 100% off-pump surgery, and Mr. Raja had been training the trainees. But I've been told that there is a program in one of the centers in Liverpool. I might be wrong, so I can ask my senior colleagues to address that.
So we don't have any formal off-pump training programs as such, but there has been a move in the society to actually have 3 or 4 centers where trainees could come for specific off-pump Cabg training. Right. So this has been discussed for a long time now, but not much seems to have happened. But this survey, I think Manish, you must publish it, or at least get it into the bulletin, because this will start a debate, and hopefully we'll have a few off-pump surgical programs established in the UK soon.
We have created a 1 or 2 year fellowship in advanced coronary surgery here at Mount Sinai Morningside Hospital in New York, which is the coronary bypass specialty center for the Mount Sinai healthcare system in New York. We accept 1 or 2 applicants for 1 or 2 years, and these are people who have finished their cardiothoracic training and want specialty training in coronary surgery with a goal of having a career focus in coronary surgery. And of course, the vast majority of my cases are done off bypass, but they're also robotic and hybrid cases, all arterial cases, no aortic touch cases, etc., that we teach residents and fellows to perform. But it's interesting, we've had very good applicants, but not hundreds of them. We have not had a deluge of applicants from around the world, despite posting it on CTS.net. I think there's a challenge in the minds of people finishing their training. They want to get out into the world and get a real job and support themselves and their families. And it may be that another year of a resident's or fellow's salary is not very attractive. Manish, do you think that there are many cardiac surgical trainees who are willing to do another year to become coronary specialists?
I think the points which you have raised, Mr. Puskas, are very valid. But one thing as a trainee, I can just comment on. First of all, there is a self-selection process, actually. When you are training into various procedures, you realize that, to do off-pump, there has to be a certain amount of confidence in yourself and also the right opportunity. Because the opportunity is not there, people with kind of not so confident with their hand movement, so they are self-selected and they rule out themselves. While I was lucky, because I had this intention, I went and I also got the opportunity, as you rightly said, I worked with Mr. Raja for 1.5 years, and that gives you enough confidence. But so as I said, there's a self-selection, plus the interest also varies. So somebody may not be interested in doing just bypass surgery. They have got varied interest. And this is not to start any debate, but my perception is that somewhere coronary surgery is not given the same ranking as other procedures what I have seen. But I think if you ask me as a trainee, the most challenging operation is coronary artery bypass surgery, which tests the skill, perseverance, and also the dedication to the specialty. Not that others are not, but this is my personal feeling.
Thank you very much.
I would agree with you, Manish. I think your point is well taken. It's past time that we had our surgical societies recognize coronary surgery not just as the most technically difficult of the procedures that we perform, but one that is worthy of being recognized as a subspecialty or super specialty. The margin for error in mitral valve surgery or aortic surgery is multiple millimeters with each stitch. The margin for error in coronary grafting is 1/10 of a millimeter.
Okay, thank you, Manish, and thank you, John. I think we are running out of time. There are a number of questions on Slido, but maybe we will leave it till the end. At the end of the session, if we have time, we will go back to this question.
That's right.
Yeah, thank you, everyone.
Thanks.
So our next speaker now is Mindaugas Norkunas from the Royal Brompton Hospital, and he is going to talk on pump versus off pump coronary artery bypass graft surgery, bleeding, products, and cost.
Good morning. My name is Mindaugas Norkunas. I'm a clinical fellow in cardiothoracic surgery from Royal Brompton Hospital. The on and off pump coronary artery bypass graft techniques are compared for many years now, and there are more than 100 randomized clinical studies published to date. We looked into our perioperative data to see if off-pump surgery provides reduction in postoperative bleeding and subsequent use of blood products, reducing the cost of in-hospital stay. In our study, we focused comparing the two groups, mainly in the postoperative bleeding, blood product transfusions, postoperative in-hospital stay, and the costs differences. This was a retrospective observational cohort study of prospectively collected data between January 2016 and January 2019. All patients underwent first-time midline sternotomy. The less invasive approaches were excluded and all the reduced surgeries as well. The two groups consisted of 1,174 patients in on-pump group and 1,020 patients in off-pump group. This table shows the patient characteristics, and we believe they're quite well matched in terms of age, gender, ejection fraction, the need for urgency for operation. We also looked into preoperative hemoglobin, platelet count, and PCV values. We believe that the statistically significant difference in preoperative hemoglobin value is due to the type 1 statistical error because of the large number of cases. Postoperative bleeding, in summary, this table demonstrates the large amount of blood loss and lower drop in hemoglobin value and platelet count in on-pump group compared to the off-pump. And also we can see that the need for reoperation for bleeding was significantly higher in on-pump group as well. As you can see, the usage of blood products was significantly higher in the on-pump group compared to the off-pump. This included red blood cells, platelets, cryoprecipitate, FFP, fibrinogen, and prothrombin in our institution. We also looked at the 30-day mortality, which was very similar between the two groups. We couldn't find any statistical difference between them. We found that the consultant as a first operator was more common in the off-pump group rather than on-pump. The length of the procedure was also shorter in the off-pump category, and the post-operative stay was statistically significantly shorter in the post-operative period in the off-pump group. To summarize our results, the average amount of drain out in the first 12 hours and totally was less in the off-pump group. The use of perioperative blood and blood products significantly less in the off-pump group. Shorter in-hospital stay in the off-pump group as well. We believe that all this results in cost saving, excluding the differences in intraoperative equipment. So to conclude, the post-operative transfusion protocol could influence the higher rate of red cell transfusions in on-pump group, as the reduction in hemoglobin value is significantly closer to transfusion threshold, which does not take into account patient's clinical status at every single time. There was a significant reduction in average cost of blood and blood products used in off-pump group, as you can see, which potentially could result in the saving of up to $82,000 per year for our institution. If we were to count the fact that the in-hospital stay was shorter in the off-pump group, that could also add another $260,000 over a 3-year period in favor of off-pump group in terms of cost savings. Thank you very much for your attention.
Okay, thank you. Shahzad, are there any questions from the audience?
There are no questions from the audience as yet.
Okay, can I ask you a question? Did you also study, do you also have data on the kind of antiplatelet agents these patients were on preoperatively? We can't hear you.
I'm sorry, can you hear me now?
Yeah.
I'm sorry about that. The data set on the preoperative antiplatelet therapy, whether they were only on aspirin or on dual antiplatelet therapy, unfortunately was not complete for all the patients. So we did not take into account that specific component. But as a trust, we have kind of a unified policy for the discontinuation of the antiplatelet therapy, which is at least 5 days for clopidogrel, and aspirin is uniformly accepted not to be discontinued before the operation.
I have a question from the audience, Vipin.
Yes, go ahead, Shahzad.
Marius Roman is congratulating you on a very nice presentation, and he's asking, did you perform a cost effectiveness analysis quantifying the ICER and quality of life increments?
No, we did not. In this case, no.
Okay, I think it's a very good suggestion, and if you're thinking of writing this up, I think you must undertake a proper, cost effectiveness analysis that would, further strengthen your study.
Yeah, thank you. We were actually more focusing not on the cost effectiveness, but on the fact of the transfusions and the length of stay difference. And unfortunately, by the pandemic, we were planning to change our protocol for postoperative transfusions, lowering the threshold to 7 grams in deciliter. And we wanted to look whether that would make a difference in terms of the amount of the blood products used, because as you could see, the PCV in both groups was completely the same. Therefore, the patients were not hemodiluted during the procedure. They were hemodiluted after the operation.
We have another question from the audience from Marius Petronas, who's asking, how are the patients randomized off or on pump? Were the surgeons who were performing the procedure the same surgeons who were performing both procedures, or were on and off pump procedures?
So they were the surgeons who were performing the on-pump procedures and the surgeons who were performing mainly off-pump procedures. So this is their choice of technique.
Okay.
Thank you very
much. I think in the interest of time, we will move on to the next presentation. Michelle Lee from Barts will be presenting on urgent cardiac surgery performed in PPE during the pandemic. Okay, Michelle.
Hello, my name is Michelle Lee from St. Bartholomew's Hospital in London. The title of the presentation I would like to share today is Urgent Cardiac Surgery Performed in Personal Protective Equipment PPE During the COVID-19 Pandemic, an analysis of operative and anesthetic times. So we would like to assess the effect on operative times for cardiac surgery performed in personal protective equipment. The COVID-19 pandemic was declared a level 4 emergency in the National Health Service in the United Kingdom. One priority was to maintain urgent and emergency cardiac surgery through the pandemic. Coronary artery bypass graft surgery is the most common cardiac procedures, and therefore provision was made to maintain this service to patients across London. In order to protect the surgical team from potentially infected patients and patients from asymptomatic but infectious staff members, the operating team were required to wear full personal protective equipment, including FFP masks and visors. This can be uncomfortable, irritating, and affect the vision. And also, there is significant difficulty in communication, especially in complex operation with background noise from suction in the operative field and alarms beeping from the monitors. So, from 23rd March 2020, all elective cardiac cases were postponed and only emergency or urgent cardiac surgeries took place at our institutions. Surgery was performed in all teams in theatres members, wearing full PPEs, including surgical gowns, double gloves, FFP masks, and visors for eye protections. Standard operating procedures requires the senior circulating nurse to record in each patient's electronic record the time into theatres, start of procedures, bypass and cross-clamp times, and end of procedures. This data were reviewed retrospectively. Patients were identified from National Surgical Database searching urgent, first-time, isolated coronary artery bypass graft surgery. Off-pump, emergency, and combined procedures were excluded. Our study population was the peak of the pandemic in London in 2020, with our control group with a similar time period in 2019. So looking at our results, from 1st April to 22nd May 2020, we carried out 42 first-time urgent coronary artery bypass graft surgeries. Mean age was 63 years old, 33 were male, 15 had diabetes mellitus, 23 had good LV function, 12 with moderate, and 7 had poor LV function. Mean number of grafts was 3, and all procedures were performed on pump. And our control group for comparison, from 1st April to 7th May 2019, we had 50 urgent Cabg, and mean age was 63 years, and 46 were male, and 24 had diabetes, and 36 had good LV, and 14 moderate, and 2 had poor LV function. So in our study population in 2020, there were no restenotomy for bleeding, 1 patient required hemodialysis, and there were no deaths. 2 patients were transferred to local hospital for rehabilitation, whilst the others were discharged home. Mean time from arrival to start of surgery was 64 minutes. Mean bypass and cross-clamp times were 86 and 65 minutes, respectively. Total procedure time was 224 minutes, and total time in the operating room was 304 minutes. And our control group for comparison in 2019, there was 1 wristonotomy for bleeding, no hemodialysis, no stroke, and no mortality. 46 patients, 92% were discharged home, whilst 4 were transferred to different hospital for rehabilitation. Mean time from arrival to start of surgery was 62 minutes. Mean bypass and cross-clamp times were 91 and 59 minutes, respectively. Total procedure time was 236 minutes, and total time in the operating theatre was 310 minutes. So in conclusion, cardiac surgery can be performed safely and in a timely fashion by surgeons in personal protective equipment. This supports our decision to continue to perform the time-critical cardiac surgery for the COVID-19 pandemic. We therefore suggest the need for an alternative PPE, especially FFP3 mask, to facilitate effective communication. Thank you very much.
Okay, thank you, Michelle. Shahzad, are there any questions from the audience? So I can ask a question. Now, with cardiac surgery, because there are no aerosol generating procedures, in Edinburgh, all we do is we wear an PP, the mask, and nothing more beyond that. So during your study period, were there any other equipment you were using for PPE besides the mask?
So as I said in the presentation, we used the double gloves and the aprons and the visors as well.
And the visors. I think
yes.
The problem with the visors is if you have loops, you can't wear them. So how did you solve that problem?
So initially, so normally surgeons will wear visors until the part he can, and then normally once you need the loops, they normally took it out. But other staff members in the theatres, they had to wear the visors during the procedures.
Okay.
Just a comment. So I was there at Barts at that time. So there was a very strict protocol. Not everybody would be allowed while the patient was being induced in the anesthetic room. So that was another precaution being taken. And yes, initial period was very tough because we were not used to. And I remember I was either, my nose was dribbling or, that was the thing. But I got used to eventually wearing these FFP3 masks for a long time. So I don't think so there was any great difference in the later part of the year. And ever since I've worn FFP3 mask, even on the wards since then.
Okay.
Yes, I agree. Thank you, Manish.
Okay, and one last question. We have a minute. So you excluded off-pump Cabg patients. Was there any reason that was done?
So in Barts, we hardly do off-pump surgeries. That's why.
Okay, that's fine.
Yeah.
Okay, I think we should move on to the next presentation. Thank you, Michelle. That was a very good presentation. And our next speaker is Mayet So Thet from St. Bartholomew's again. And the topic is routine use of epicardial pacing wires leads to longer hospital stay in patients undergoing isolated Cabg surgery. The next presentation, please.
Good morning, ladies and gentlemen. My name is Mayet. I'm from Department of Cardiothoracic Surgery at St. Bartholomew's Hospital. Today, I'd like to talk about the routine use of epicardial pacing wires with regards to outcomes following cardiac surgery, especially isolated CABG surgery. As we all know, epicardial pacing wires are routinely used in cardiac surgery. Although rare, they may be associated with serious complications leading to most commonly cardiac tamponade. Currently, there is very little data available in relation to the use of epicardial pacing wires and the outcomes following cardiac surgery. The aim of our study is to examine the outcomes of the patients who underwent cardiac surgery at an institution with respect to the use of epicardial pacing wires. This is a retrospective analysis of 2,111 patients undergoing cardiac surgery between January and December 2018. All the patients were divided into 4 groups based on the procedure they underwent. The first group is isolated CABG, the second group is isolated valve, the third group is CABG and valve, and the fourth group being other procedures such as aortic surgery. Patients in each group were further divided into those with epicardial pacing wires and those without the pacing wires. The following outcomes were examined, being mortality, complications, postoperative length of stay in the intensive care, and total length of stay in the hospital. If we look at the results, 86.3% of the patients had epicardial pacing wires inserted following cardiac surgery. And in isolated CABG group, about 80% of the patients had epicardial pacing wires, whereas the valve group, isolated valve group, has got almost 100% patients had pacing wires. The remaining 3 patients had permanent pacemakers inserted preoperatively. In the third group, CABG and valve group, all patients had epicardial pacing wires inserted, whereas in the fourth group, other procedures, about 70% of the patients had epicardial pacing wires inserted. If we look at the mortality rate between the patients who had pacing wires and those without pacing wires, they're comparable. It's about 3.1% versus 4.5% with a p-value of 0.23 and a re-exploration rate of 3.9% versus 4.2% with a p-value of 0.78, stroke rate of 2.1% versus 1.7% with a p-value of 0.7, and postoperative new renal dysfunction requiring hemodialysis rate of 4.6% versus 5.5% with a p-value of 0.46. If we look at in details of the 4 groups, isolated CABG and isolated valve group, as you can see, the total length of stay has got significant p-value. Patients without pacing wires tend to stay shorter. Those compare with the patients with pacing wires in the isolated CABG group, as well as the isolated valve group, whereas the remaining outcomes such as re-exploration rate, stroke or transient ischemic attack, new hemodialysis after surgery, ITU length of stay, and new permanent pacemaker insertion rate were the same in these groups. We did not have any patients who without pacing wires in CABG and valve groups and other procedures group. These all parameters are comparable in both patients with pacing wires and those without pacing wires. Epicardial pacing wires are usually placed in patients undergoing valve surgery, especially valve repair or replacement surgery. This is due to the increased risk of complete heart block following the valve surgery. Epicardial pacing wires are also used in belief that they may improve the patient outcomes on the intensive care unit, and also to detect patients who are likely to require permanent pacemaker post-operatively. The complications of the associated with epicardial pacing wires, those include infection, damage to the myocardium, ventricular arrhythmias, perforation, and cardiac tamponade. If we are to conclude, the routine use of the epicardial pacing wires appear not to influence survival or complication rates following cardiac surgery. In isolated cardiac surgery, in isolated CABG cases, insertion of the pacing wires leads to longer hospital stay without improving the outcomes. Hence, the use of the epicardial pacing wires in isolated CABG group should be reserved for selected patients. Thank you.
But I would say pacing wires are put in. I put in pacing wires in all my patients. It's just because to take care of the very rare complication of an asystolic cardiac arrest in the post-operative period. And you said patients who had pacing wires stayed longer in the Cabg subgroup. Why would that be? Do you have any Any reasons?
So, Webber, I don't think that Dr. Tet is in the room at the moment.
Oh, okay.
But it's interesting that you put pacing wires in all your patients, and I don't put pacing wires in any of my Cabg patients. You know,
So-
and I think the practice varies. But for some reason, you know, I have yet to come across a Cabg patient, because I do off pump, you know, like you. Surprisingly, I mean, I don't put pacing wires. I've never come across a patient who's required an intervention because of rhythm disturbance following an off pump Cabg, where, you know, they've had a life-threatening event. And if, you know, for my Cabg, non-Cabg patients, you know, when I do, you know, use pacing wires, I have, you know, come up with a slight modification of the standard technique so that we can reduce this, you know, feared complication of tamponade. So what I would normally do is I would put one wire through the ventricular muscle, and the other wire is put on the inferior surface on the pericardium, so that the heart sits on that pacing wire. And so when you remove the wire, you've already, you know, when you place the wires in, you've already reduced your risk of bleeding by 50%. And I don't, you know, make, you know, these funny shapes that people tend to make with the pacing wires to ensure that they're not pulled out. I just leave the wire straight in through the muscle, and it just comes out very easily. So, you know, the rate of cardiac tamponade following pacing wire removal is pretty much neglected in my experience. And also, I mean, on the right atrium, what I would normally do is I put the pacing wire similarly straight through that, you know, nipple of tissue that you have at the end of, once you've tied off the atrium, so that it doesn't go through the atrial tissue itself. It goes through that bit of muscle which you know, have above the tie. And the other pacing wire I put on the roof of the LA. And that way, you know, you reduce your risk of bleeding by pretty much 50%, if not 100%. So I think, you know, I think, you know, I do agree with the presenter that yes, they do have an impact on your length of stay, because funny enough, most patients would tend to go home on weekends for some reason, and, you know, no one wants to pull out these pacing wires on weekends. So I think, you know, there is an impact of, you know, this strategy on the length of stay, and I feel that, you know, we sometimes tend to just overdo things. You know, I think that inherent fear of one event happening in 1,000 patients is what, you know, tends to impact our practice. But, you know, those who do it, I'm sure they're justified in doing it, and then those who don't, I'm sure they are justified in doing it. I don't know what John's view is about that.
Dr. Raja, I like you, I rarely put pacing wires in my coronary patients. I do routinely put them in patients who have valve surgery or valve combined coronary surgery. My general rule of thumb is if we're doing an off-pump bypass operation, which is our norm, and we do not need to pace the heart during the operation, then we don't need to pace the heart after the operation. So if the patient needs a pacing during surgery, they get pace wires after surgery. That's a small number, less than 10% of OpCabs. The other one group where I'm tempted to do it is any patient that's demonstrating a propensity to go into AFib. You know, if the patient has no history of atrial fibrillation but comes to the OR for off-pump bypass and with a little manipulation is in AFib, and then you have to do an internal cardioversion to sinus rhythm to complete the operation, I will usually occlude the appendage with a clip and leave pacing wires in anticipation that I may need to give that patient amiodarone after surgery, and that, you know, in the uncommon event of bradycardia, being able to AV pace afterwards is useful. And I'll add that when I do pacing wires, again, it's infrequent, but when I do, I always put atrial and ventricular wires, because you know, God designed the heart to have a upper and lower chamber function in synchrony, not to have V pacing. So if one is going to put pacing wires in, I would encourage the use of AV pacing rather than V pacing alone.
Right.
Okay. Thank you, John.
Better.
Okay, so let's move on to the next presentation now. Our next speaker is Tom Rayner from Bristol, and he'll be talking on evaluating joint association of body mass index and diabetes with late mortality after CABG.
Hello, my name is Tom. I did this project as a Bristol medical student in conjunction with the Bristol Heart Institute. We evaluated the joint association of BMI and diabetes on late mortality after Cabg. So several studies have made reference to an obesity paradox in patients undergoing Cabg. Diabetes is strongly linked to increased late mortality after Cabg, and obesity and diabetes are highly associated, but the joint effects on late mortality after this procedure are seldom assessed. And so we try to fill that gap by assessing the interactive effect of obesity and diabetes on late mortality, specifically after Cabg, in a large cohort of Bristol patients. We stole our data from the NAXA dataset, so it's 15,129 patients who underwent isolated Cabg at the BHI between 1996 and 2017. Divided our BMI categories as per WHO criteria, and we defined diabetes. Essentially, we dichotomized it. They did or they didn't have diabetes, regardless of their type or their control, how it was controlled. To assess the joint effects of obesity and diabetes, we created 8 joint categories dependent on their diabetes status and their BMI category, so as normal weight non-diabetes, normal weight diabetes, and so on and so forth. And we used all-cause late mortality as an endpoint for our analysis. We looked at preoperative characteristic differences between each of the BMI categories. We created univariable Cox proportional hazard models by taking covariables from the NAXA dataset, running them against late mortality to see if they're associated with late mortality, and the ones that were significantly associated with them put into multivariable Cox proportional hazard models. We looked at the independent effect of diabetes and BMI on in those models, and then we put the 8 categories, the BMI diabetes categories, into the same model to look for the joint effects on late mortality after Cabg. We also introduced an interaction term into the independent models to look for a significant interaction between the 2 covariables. This is the baseline characteristics. So you can see 21% of patients had diabetes. Most of the patients were pre-obese, so 7,103 of them. They also had the highest burden of preoperative comorbidity. And the differences in baseline characteristics were very significant. You can see on the left, the Kaplan-Meier survival curve shows a pretty obvious outcome that diabetic patients essentially had extremely increased or elevated hazards of poorer survival, essentially, compared to non-diabetic individuals in the independent effects model. And on the left, somewhat more interesting, is that the pre-obese patients or the overweight patients did better in terms of their survival compared to normal weight individuals. So there was sort of a pre-obese paradox, but that didn't exist for your kind of your class 1 obese, class 2 obese patients. The class 1 obese patients, there was no evidence that they were worse or better hazards of survival compared to normal weight individuals, and class 2 obese patients did significantly worse. So in terms of the joint effects, the underlined or highlighted areas, our referent group, are normal weight non-diabetic patients. The green circles represent the non-diabetic pre-obese and the non-diabetic class 1 obese patients who had significantly reduced hazards of late mortality compared to the non-diabetic normal weight patients. So it shows there is some evidence that there is a kind of pre-obese or class 1 obese paradox, but only existed in non-diabetic patients. As soon as you introduce diabetes, you can see that the hazards of late mortality increase significantly, and there was a significant interaction. You can see here P for interaction 0.026. And this highlights that very nicely, I think. So the diabetic sort of blue line, you can see they're very much higher in terms of their hazards of late mortality compared to normal weight non-diabetics. And then there's that small but present association between pre-obese non-diabetic and class 1 obese non-diabetic patients, and slightly improved survival compared to normal weight non-diabetics. So our study does demonstrate the impact of diabetes on late mortality for all categories of BMI, and there is a significant interaction between BMI and diabetes. We've shown that pre-obese and class 1 obese non-diabetic patients appear to do better than their normal weight non-diabetic counterparts, but the mechanisms behind this are poorly understood. We have a large population, high quality data in terms of the strengths of the study, but we only had 1 centre's worth of data. We didn't consider other things such as in-hospital mortality, and further studies should look to address reasons for the obesity paradox and to look at other endpoints such as kidney injury and time spent in hospital. These are my acknowledgements, my references. Many thanks.
Okay, thank you, Tom. That was a very good presentation. So
Thank you very much.
can I say a take-home message is, if you are not a diabetic, you can be slightly overweight, and that will be okay. Is that?
Don't be so self-congratulatory, Vipin.
Can you hear me? Yeah. Firstly, I think it's very difficult to kind of draw sort of conclusions from it, considering it's an observational study. But I think we don't know whether or not it's related to kind of reverse causality, or could it be selection bias? So your obese patients might actually be at sort of elevated risk of of mortality, and therefore they're excluded before they're even put into the study. But I think essentially what we're trying to demonstrate is that a lot of the studies that are looking at the obesity paradox don't really consider these quite complex interactions between variables that are associated with both BMI and late mortality. So what we're demonstrating is essentially that there is these interactions that need to be considered in future studies, essentially.
Tom, let me propose a second or an alternative explanation. And
Okay.
this
Please do.
would make the case that you've chosen, you have broken BMI into categories.
Sure.
And you have no category for underweight.
Yes.
You have anybody who wasn't obese or pre-obese is normal, but that's not actually the case.
No.
There are underweight people who come for coronary surgery, and they are actually a vulnerable and frail population.
Sure.
A cachectic patient near the end of life with coronary disease that cannot be managed percutaneously has coronary bypass surgery, and that person is actually at a higher risk of mortality than a pleasantly plump individual.
Sure.
Especially if the pleasantly plump individual does not have diabetes. So I would suggest that you redo your analysis using BMI as a continuous variable rather than a categorical variable. And I think you'll see a U-shaped curve with greater risk in the very frail, emaciated patient and greater risk in the obese diabetic patient, but at the bottom of the U will be the normal people.
Sure.
And that is something that we've actually demonstrated before in a variety of ways. And there's a paper that I published, it's a decade and a half or 2 decades ago, looking at outcomes and early and late outcomes in coronary surgery using BMI as a continuous variable rather than a categorical variable. I think that the notion that pleasantly plump is better than normal simply reflects the fact that you put the scrawny in with the normal.
So we actually excluded the underweight individuals.
Okay, thank you.
Yeah. And I wouldn't do that because if we're talking about body mass index, we have to use the whole spectrum of human body mass indices.
Tom, we have one question from the audience. Ricky's asking, did you look at HbA1c levels?
No, so we didn't have access to that from the NAXA data set, so it wasn't part of our preoperative characteristics. So I think for simplicity terms and the way we had split up the 8 groups to demonstrate the interaction.
I think you're on mute.
Am I on mute?
No, we can hear you, Ricky. We can. Sorry, Tom, we can hear you.
Can you? So the way we wanted to illustrate the data was simpler if we just dichotomized the BMI, so the diabetes group, into either having diabetes or not. I think otherwise we would have ended up with sort of 20, 25 different categories or outcomes. So it would have been much harder for us to kind of illustrate our findings. But I agree that probably we could do with breaking it up per sort of how the diabetes is controlled and what type of diabetes patients have.
And I think Dr. Puskas has done a lot of work on HbA1c. I don't know whether he would want to add to what you've said, but I think your diabetic control has got some influence on how you...
Absolutely.
It certainly does. Well-controlled diabetes does not portend the same risk of early or late mortality as poorly controlled diabetes. Having diabetes is a bit of an IQ test. If you don't manage your diabetes well, you flunk the test, and you don't live as long.
Sure.
Okay. All right, Whippen, you want to introduce the next speaker? Thank you, Tom.
Thank you very much.
For some reason, we can't hear you, Whippen. So I can introduce our next speaker is Ahmed Mohamed Abdul Shafi, presenting Management of Prognostic Coronary Artery Disease During the COVID-19 Pandemic, a Single-Center Experience. Dr. Shafi.
Dear respected colleagues, I would like to thank the Society today for allowing me the opportunity to present our study, which is looking at the management of prognostic coronary artery disease during the COVID-19 pandemic at our center. As we are aware, COVID has had a significant impact across all healthcare systems globally, and studies have shown that COVID-19 infection affects directly the cardiovascular system, resulting in vascular inflammation, plaque instability, and myocardial inflammation, and predisposes to worse outcomes. During the peak of the outbreaks of COVID-19, in the UK, healthcare systems underwent emergency restructuring and reallocation of resources with cancellation of elective surgical cases across all surgical specialties. In terms of cardiothoracic surgery, services were centralized in order to provide emergency surgical care. We aim to assess the impact of COVID-19 on the management strategies employed in patients with prognostic coronary artery disease at our institution. We looked at a period of 23rd of March to June 2020 and identified patients who had prognostic artery disease, classified as left main stem disease, single vessel disease with proximal LAD stenosis, triple vessel disease in diabetics, and triple vessel disease with impaired left ventricular ejection fraction. Our exclusion criteria included patients who had PCI for ST elevation MI or for a planned PCI during this procedure, or were having investigations for surgical procedures. In terms of result, 813 patients underwent angiography during this period. 141 of these patients fulfilled inclusion criteria. 74 patients underwent PCI. 30 patients underwent coronary artery bypass surgery, with an additional 24 patients accepted for surgery and placed on the waiting list, with their operation performed after our study period. 12 patients were treated medically for their disease. In terms of demographics of both groups, or in terms of surgery and PCI, we find that gender and age was similar in both groups. However, there was a significant high incidence of previous TIA and stroke and previous MI in the surgical group. Looking at the indication for the presentation to hospital and for the indication of coronary angiogram, we find that the majority of patients had non-ST elevation MI, and in terms of proportion compared for PCI and surgery, significantly higher proportion of surgical candidates had that as their initial presentation, which was significant. And we find that the other two main reasons were for unstable angina and stable angina. In terms of the urgency of procedure, as expected, most of these cases were done as urgent cases, very few as emergency. And in terms of the elective, these were patients who were admitted, had their angiography performed, and were allowed home and to be brought back as a planned procedure, as they could not wait for an extended period of time, and they were classified as elective cases. And we can see that the majority of surgical cases were isolated coronary artery bypasses. In the PCI group, one patient was COVID positive during their admission but developed no complications, and 19 of the 74 patients were discussed in MDT, and 12 of these were following MDT recommendations. 4 declined surgery, and 3 had extensive comorbidities that indicated that they should not be having surgery. In the surgical group, no patient tested COVID positive during their admission. 3 patients had PCI to their culprit lesions before surgery. 1 patient required PCI in SAVI 1 month after an emergency Cabg. This was due to a porcine aorta found intraoperatively. In terms of in-hospital death, there was no deaths in the primary PCI group. However, in the surgical group, there was 2, but this did not reach any significance, and this death rate did not change at 30 days. In conclusion, clear guidelines advocate the use of surgical intervention over PCI in recognized patterns of coronary artery disease due to the prognostic long-term benefit. However, as we all know, surgery utilizes precious intensive care resources which were needed to manage the exponential burden of COVID-19 during the peaks of its crisis. And in circumstances that has necessitated the need, a short-term change in management of prognostic coronary artery disease was required. However, a significant proportion of patients with coronary artery disease of surgical pattern had PCI. Therefore, these patients with prognostic coronary artery disease should be discussed in an MDT setting, and ideally PCI should be offered to treat the initial culprit lesion, allowing for an opportunity for surgery to be scheduled. And these patients need to be studied up to understand the true impact that the changes in management have ultimately had. Thank you very much. Surgery utilizes precious intensive care resources which were needed to manage the exponential burden of COVID-19 during the peaks of its crisis. And in circumstances that has necessitated the need, a short-term change in management of prognostic coronary artery disease was required. However, a significant proportion of patients with coronary artery disease of surgical pattern had PCI. Therefore, these patients with prognostic coronary artery disease should be discussed in an MDT setting, and ideally PCI should be offered to treat the initial coverage.
Okay, great. Thank you, Dr. Shafi, for a very good presentation. My question to you is that, did you have an MDT process at the time when these procedures were performed? And if so, what was the decision-making process which obviously affected the choice of intervention for these patients? Can you hear us? I think he's left the room. Well, he's rejoining the room. We can't hear you, Vipin, for some reason. Okay. Okay, let's see if Dr. Shafi is joined. If not, then I think we'll okay. Okay, so we'll move on to our next presenter, which is Dr. Ricardo Abbaciano, and he's going to talk about the impact of ethnicity on access to intervention in patients treated for coronary heart disease, a systematic review and meta-analysis. The floor is yours, Dr. Abbaciano.
Esteemed moderator and dear colleagues, thank you for allowing me to present our work today, which is on the, before I start, I want to highlight how this work is designed as a starting point in answer to a research need identified by patient groups, and whose importance is reflected by recent initiatives, such as the institution of the NHS Radial Artery Observatory. It goes without saying that coronary artery disease constitutes one of the most concerning health issues in developed countries, with a huge burden in terms of mortality, morbidity, and of course, economical implications. A long-standing ongoing research topic in the field of revascularization has demonstrated how the ethnic backgrounds might have an impact on the outcome of the revascularization. For instance, in CABG recent series, it was showed a significant trend toward lower mortality rates, and in most recent series, an improvement among Black nation patients. However, the relative disadvantage between the study groups is still there. Our question, however, is a bit different and aims to ascertain whether patients are being offered a different therapeutic strategy for their condition based on their ethnicity. So, applying a Cochrane methodology, we ran a comprehensive literature search for studies assessing treatment approaches for coronary artery disease among patients from different ethnic groups. To express this in form of a PICO, the E in PICO would stand as exposure, in this case, the ethnicity. We anticipated potential difficulties related to the kind of studies that we would find, and of course, how this study would have been employed in a numerical synthesis. So we planned from the protocol phase a qualitative synthesis too, by means of a modified grade circle approach. And these are our results. So we obtained almost 5,000 references. We ended up with a short list of 28 studies. The entire quantitative analysis included 1,004,000 patients approximately. And as you can see immediately from the first plot inspection, the evidence emerging from this study is severely heterogeneous. This will obviously limit the certainty of the findings in a pooled analysis, but it should not prevent us to at least have a general look at the data, and that seem to consistently point in the same direction, both from the analysis of the adjusted odds ratio and the unadjusted odds ratio. So pooled and adjusted odds ratio show that overall there are no difference in the vascularization between white and non-white patients. However, looking specifically at Black or Hispanic patients, we realize how they are less likely to undergo revascularization compared to white. Specifically, non-white are less likely to have PCI compared to white, and that seems to be related to the fact that Black patients are less likely to have PCI compared to white, but not Hispanic or or Asian patients. And similarly, non-white patients are less likely to undergo CABG compared to white. And this is due to the fact that Black patients are less likely to have CABG compared to white, but not Hispanic or Asian. The qualitative analysis of the data corroborates the results that we obtained in the quantitative one and provides some additional insights. For instance, the timing to get reperfusion are longer for Black and Hispanic patients. Moreover, the generalizability of the study findings to non-USA population is limited. Firstly, the demographics of the USA and non-USA population are a bit different. And in the UK people, the participants from the Asian ethnic groups, of course, make up the second largest percentage of the population, followed by the Black ethnic groups, while Blacks or African American make the largest minority in the USA. At last, we used the Robinson to run a risk of bias assessment for the paper included, and as you can see, there are several limitations. With an overall risk of bias that is at least moderate. In conclusion, our review of the literature shows how the access to care as a team is substantially less explored than the outcomes of the revascularization. But despite all these limitations, our analysis consistently highlights how there are potential disparities in access to revascularization based on ethnicity. This defines, of course, an area of research that will greatly benefit from a robust national analysis of the S data, coupled with patient-led initiatives and the involvement of the BAMI groups. Thank you.
Okay, Shahzad, are there any questions from the audience?
Well, there are no questions from the audience, but I have a question for you, Dr. Abbasiano. Very interesting. I mean, I think in an era of equality, diversity, and inclusivity, I think this is a very important study. But what I found very interesting was that the latest study that you've included in your meta-analysis from 2009, am I right in that? And that there is no work which has been done on this important aspect since 2009. So I guess we need to probably start looking at this aspect.
Thank you for the questions, and you're absolutely right. One of the main limitations, probably I should have highlighted it more, is that the studies are quite old, but despite that, they are consistent throughout the years in pointing out how the differences among the ethnic groups in access to both options of vascularization are different. Most of the studies were conducted in the US, which of course has a different system compared to the UK, but still the UK ones highlighted similar issues. And we explored the heterogeneity to try and find if some moderators, like the year of the studies, could help explain the differences. And actually, the year of publication of the studies could explain, could make us notice a partial improvement in the access to PCI, but not Cabg. So it seems that cardiologist colleagues are improving a little bit, but still, like you were saying, we need to focus on this because this has been highlighted for quite a while, and we haven't clearly done much to address it.
Great, thank you.
I have marveled at the politicization of these conversations, especially over the last few years, and the lack of real scientific rigor in analyzing the data. And also I've marveled at the gap between my own personal experience and observations as a American physician for the last 30 years and what is reported as a divergence in access to care. I have never, ever witnessed healthcare delivered in my hospitals where I've worked over my career be different based on the race of an individual, ever, not once. And I don't know of any physician in my colleague group who would consider that acceptable or ethically appropriate. I do recognize that the American medical system has a financial component which discriminates in effect against those who have less money than those who have more money. Patients who can buy private insurance generally have different care than patients who do not. Although that gap, I have to say, in the academic medical system does not exist either, because just arriving at an emergency room in America allows you access to all care. I think it's very important to not mix race with socioeconomic status. They are, it's a profound confounder, especially in a healthcare system where money plays a role, as it does in the United States. I think it's also important not to confuse care delivered versus access to care, because different groups will take advantage of access differently. And there are some cultures that are trustful of healthcare in general, and some cultures that are not trustful of healthcare in general, especially more technologically or advanced or invasive healthcare. So there are a lot of confounders. It is not, I think it's profoundly simplistic to point to differences in the utilization of healthcare as being equivalent to differences in the access or availability of healthcare. And I think that the access issues are often socioeconomic and cultural and no longer based on race. I think those are really important considerations.
Okay, I think we are running out of time. This is a very interesting topic and we could speak for hours on this. There are many issues outside the hospitals which also determine how patients access care, etc. But that is for another time. So let's move on to the next speaker, Francesca Gatta, who is going to speak on short and long-term impact of diagnosed and undiagnosed COPD on CABG surgery. Francesca is from Hull.
Good morning. Thanks to the SCCS for running this inspiring event. My name is Francesca Gatta. I'm a clinical research fellow in cardiothoracic surgery at Castle Hill Hospital. And today I'm going to talk about a topic we're all very familiar with, but from a new perspective, and that is the compared impact of diagnosed and undiagnosed COPD on coronary artery bypass grafting surgery. COPD has been acknowledged to be an independent risk factor for morbidity and mortality in cardiac surgery. Indeed, it is included in most of the risk stratifying scores. However, the widely used Euroscore only considers COPD in the presence of a clinical diagnosis, which includes long-term use of bronchodilators. Moreover, the literature regarding the impact of lower predicted Phe1 lacks consensus. Therefore, this study sought to analyze the impact of two categories of patients, diagnosed and undiagnosed COPD, on coronary artery bypass grafting surgery, as well as stratifying the risk according to the predicted Phe1. A population of 4,020 patients undergoing Cabg only from 2010 to 2019 was included. This was divided into three cohorts: non-COPD, diagnosed COPD with a clinical diagnosis, as I mentioned earlier on, and undiagnosed COPD, which includes patients not known to have the disease, but with preoperative spirometry results indicative of COPD. The latter two groups were then further divided according to the gold criteria in relation to the predicted Phe1. For numerical variables, the two-tailed t-test followed by a Bonferroni correction test was performed, whilst for non-parametric variables, the Pearson's chi-square was utilized. For long-term survival, the Kaplan-Meier method was considered. Primary outcomes were postoperative complications, intensive care unit and total hospital stay. Secondary outcomes were reintervention rate, in-hospital and long-term mortality rate. Looking at the primary outcomes, no statistically significant results were detected in the rate of arrhythmias, gastrointestinal and neurological complications, multiple organ failure, and intensive care unit length of stay. However, prolonged total hospital stay, greater wound and renal complications resulted in non-COPD patients. Additionally, both COPD patients and unknown COPD patients had a higher rate of respiratory complications. A further analysis was conducted to detect the mutual nature of the results, and respiratory complications were higher in Group B than Group C, higher in Group C than Group A. These included atelectasis, hospital-acquired pneumonia, pleural effusion, pneumothorax, ARDS, and prolonged ventilation. For these variables, no statistical analysis was performed to avoid a bias due to missing data. Looking at secondary outcomes, no statistically significant results were detected in the reintervention rate and short-term mortality rate. However, long-term mortality was higher in both known and unknown COPD. Again, a further analysis was conducted to establish the mutual nature of the results, and both these groups had equally higher number than non-COPD patients. The Kaplan-Meier for long-term survival showed a similar trend in the three cohorts. Finally, a further analysis was conducted to correlate the long-term mortality with the predicted phe1 in diagnosed and undiagnosed COPD patients. No statistically significant results were reported. However, the Kaplan-Meier for long-term survival showed a steady decline after year 4 for expected phe1, higher than 50% in diagnosed COPD, and after year 3 for the same category in undiagnosed COPD. Unfortunately, this was also a limitation of the study, as the number of patients with lower expected phe1 was very limited. To conclude, patients with a known clinical diagnosis and patients with a preoperative spirometry diagnosis of COPD report similar outcomes for respiratory complications and long-term mortality in coronary artery bypass grafting surgery. Consequently, the Euroscore should perhaps consider a spirometry diagnosis of COPD alongside the current clinical definition. Lastly, our study failed to demonstrate a risk stratification according to the expected phe1. Thank you.
Thank you, Francesca. Are there any questions from the audience, Shahzad?
No questions as yet, Vipin.
Should we, I think we are running late now. Should we move on to the next session?
I think so. I mean, thank you, Dr. Gatta. Excellent presentation. Well done.
Thank you. Thank you.
Okay, and our next session now is the Tudor Edwards lecture. Tudor Edwards was a thoracic surgeon who lived in the first half of the 20th century. He practiced in London and he pioneered many operations for pulmonary tuberculosis and lung cancers. After his death in 1946, his colleagues got together and set up a fund to endow a lecture in his memory. The lectures have been an annual event since 1948, and they have been administered in alternate years by the Royal College of Surgeons and the Royal College of Physicians. In 1997, it was agreed that when it would be the turn of the Royal College of Surgeons, the lecture would be administered by our society, and the lecture would be delivered at our annual meeting. This lecture has been delivered by some very illustrious surgeons in the past, and that tradition continues today. And it's my privilege today to introduce to you today's speaker, John Puskas. John is a very dear friend, and I've known him for more than 20 years now. Our acquaintance in those initial days started with our mutual enthusiasm for off-pump coronary artery bypass graft surgery. John has been one of the leading figures in the OpCav movement. He performed one of the earliest randomized controlled trials comparing off-pump and on-pump coronary artery surgery. The SMART trial was a very meticulously conducted study, and it showed significant benefits with off-pump surgery in the short term and equivalent results in the long term. John Puskas also has to his credit that in 1997, he performed the world's first triple, quadruple, and quintuple off-pump coronary artery bypass graft surgery. And to date, he has performed more than 5,000 op-cab operations. He also has an interest in robotic surgery, and he has performed more than 500 minimally invasive robotic coronary procedures. In 2015, along with David Tagret, he co-founded the International Coronary Congress, and this annual meeting is held in New York every second year and in some other part of the world in alternate years. I have been a faculty at a few of these meetings in New Delhi, New York, and Beijing, and I can say that this Congress is perhaps the best educational experience for the practicing surgeon as far as coronary artery surgery is concerned. John Puskas has also co-edited a textbook, The State of the Art Coronary Revascularization, and this textbook was published just this year. John is chairman of the Department of Cardiovascular Surgery at Mount Sinai in New York, and is professor of cardiovascular surgery at the ICANN Medical School at Mount Sinai. So ladies and gentlemen, let's listen to John Puskas on the future direction of coronary surgery. John?
Hello, I'm John Puskas. It is my great honor to deliver the 2021 Tudor Edwards Lecture entitled The Future of Coronary Surgery. These are my disclosures. Perhaps most relevant is the fact that I have devoted my career to coronary surgery and believe that we must continuously advance the field. Arthur Tudor Edwards was a courageous surgical innovator during both wartime and peacetime. He was intellectually curious and investigated multiple different thoracic pathologies and developed numerous thoracic surgical techniques. He was a visionary, credited with establishing thoracic surgery as a specialty in the UK, and an educator who trained a generation of thoracic surgeons. He was a tiger for work and an operator of supreme skill and beautiful technique. His colleagues established the Tudor Edwards Lectureship in 1948. After his premature death in 1946, it is my deep privilege to join the list of cardiothoracic surgeons who have delivered the Edwards Lecture since 1948. Now, I was assigned the topic of the future of coronary surgery, and not too very long ago, some might have questioned whether coronary surgery had a future. Well, I am confident that it does, and that we must make that future. Doing so will require that we demonstrate the same qualities that characterize Tudor Edwards: innovation, intellectual curiosity, a willingness to evolve techniques and develop new training paradigms, and to work hard. Abraham Lincoln is often credited with the statement, "The best way to predict the future is to create it." I will state that in the near future, we must bridge the gap between best evidence and common practice in coronary surgery. We must continually evolve our techniques because we must evolve or perish. And we should institute new training paradigms and recognize coronary surgery as a subspecialty, or I'd rather say a super specialty. I believe that we will see more, not fewer, cases for coronary surgery. The aging population and the epidemic of diabetes and cardiometabolic syndrome in the developed world mandates that, since coronary surgery is the only surgical therapy for coronary atherosclerosis, which kills more human beings than any other disease. I believe we will see more young patients referred with premature coronary disease for multi and all arterial bypass grafting, but we will also see more complex cases with multiple in-stent restenosis and full metal jackets in patients for whom PCI has been exhausted. We will see more demand for alternative access CABG, robotic CABG, and hybrid coronary revascularization. And I believe we will see coronary surgeons and interventional cardiologists work ever more closely together, I hope within organizational structures that remove financial disincentive to patient-centered and evidence-based care. Coronary surgery is here to stay, in large part because of these sorts of findings. This is the FREEDOM trial, a large cohort of diabetic patients randomized with multivessel disease to receive multivessel PCI or coronary bypass. And we see at 5 years a striking benefit of CABG over PCI for death, stroke, and myocardial infarction. At 7 years, the survival benefit continues and expands. The SYNTAX trial 5-year results for left main and multivessel disease in the overall cohort also demonstrated an advantage of Cabg over PCI for myocardial infarction, repeat revascularization, death, stroke, or MI, or MACE. In the multivessel disease subgroup, for patients with intermediate or high syntax score, coronary bypass beat PCI hands down. This led the authors to conclude in the Lancet that 2/3 of all patients with complex coronary disease are still best treated with coronary bypass. And this may have to do largely with the fact that the consequences of stent failure and graft failure are very different. Stent failure commonly leads to cardiac death, while graft failure infrequently does. This may explain why the mortality benefit in multivessel disease in the Syntax trial extended and expanded through 10 years of follow-up, almost 1% per year in favor of Cabg. I recommend to you this Journal of the American College of Cardiology Review Topic of the Week paper from 2019, dissecting the reasons why Cabg, but not PCI, prolongs life in stable ischemic heart disease. This meta-analysis demonstrated that about 3/4 of RCTs comparing Cabg and PCI showed a survival advantage for Cabg. But that survival advantage only was seen in trials where late myocardial infarction was reduced more by Cabg than by PCI. And this suggests that the mechanism of the survival advantage of Cabg over PCI is the prevention of new myocardial infarction. And this makes sense because stents address focal flow-limiting lesions in proximal vessels and do not treat non-flow limiting lesions where future plaque rupture or thrombosis may produce myocardial infarction. By comparison, coronary bypass bypasses the proximal half or 2/3 of the coronary artery, bypassing flow-limiting and non-flow-limiting lesions that are present or that may be present in the future, preventing future myocardial infarction. Now, I want to switch gears and talk about the gap between best evidence and common practice. The near future of coronary bypass must be to eliminate that gap. We're going to focus on multiple issues, including epi-aortic ultrasound, single cross-clamping for on-pump and clampless off-pump surgery, the addition of a second arterial graft for every patient having coronary surgery, intraoperative graft assessment, ablation of atrial fibrillation in patients coming with AFib for Cabg, and the administration of optimal medical therapy for all Cabg patients. Why is epi-aortic ultrasound important? Because stroke is the Achilles heel of Cabg. These are the Syntax trial data through the first 1 year, demonstrating that stroke is more common after Cabg than after PCI. The same was found in the Freedom trial. Stroke is the Achilles heel of coronary surgery, but we can mitigate against that risk by carefully planning aortic manipulation and avoiding it whenever possible. We should perform epi-aortic ultrasound routinely. It takes 60 to 90 seconds and can reveal these sorts of aortic atheromata that cannot be palpated anteriorly. Even this medial thickening can be extruded with application of a partial clamp, and such lesions are typically not palpable. We studied 10,000 patients and with respect to the relationship between clamp strategy and stroke incidence. We found that an on-pump 2-clamp technique had the highest risk of stroke, while an off-pump no technique had the lowest risk of stroke. This was found also by Borgeman in a propensity match study of about 400 pairs of patients who had clampless off-pump versus conventional on-pump, demonstrating striking reductions in the in-hospital risk of death or stroke. This is how we create a proximal anastomosis on the ascending aorta when we must do so. I have not put a clamp on the aorta for coronary surgery in over 10 years. This heartstring device allows us to construct a relatively bloodless proximal anastomosis without a clamp. This is a study of 40,000 patients, a meta-analysis, broken into 4 groups: on-pump coronary bypass, off-pump Cabg with partial clamp, off-pump Cabg with heartstring, and no aortic touch and aortic off-pump bypass. In this hierarchical meta-analysis, you can see that anaortic op-Cabg stands at the top of the pyramid, with greater benefit in terms of stroke reduction, mortality reduction, myocardial infarction reduction, renal failure, bleeding, and atrial fibrillation reduction than any of the alternative surgical techniques. And that is why this is my favorite operation: no aortic touch and aortic off-pump bypass with dual internal mammary artery inflow and radial artery outflow. That's not just my favorite. It can be done by other surgeons too. Alexander Albert directed his entire department in Dusseldorf to adopt a no aortic touch and aortic OPCAB technique. And compared to the historical controls, they reduced the incidence of early stroke in their entire department by 90%. Here, as you can see, as aortic OPCAB increased, the risk of early stroke plummeted. This is why the European Association guidelines recommend that we minimize manipulation of the ascending aorta and perform epi-aortic ultrasound routinely. Off-pump bypass should be performed by experienced operators and preferably with no-touch techniques. Now, the provision of a second arterial graft can be accomplished in multiple ways. Classically, it's with two internal mammary arteries. This is the Cleveland Clinic paper from 1999 demonstrating that survival and event-free survival was superior for beta than for theta. And this has been emphasized that reoperation and event-free survival are superior with double mammary grafting compared to single mammary grafting with multiple editorials. And that is true irrespective of whether we harvest the mammary artery as a pedicle or as a skeletonized graft. Now, I want to spend just a moment talking about David Tagret's ART trial, published in New England Journal recently. This randomized 3,000 patients to have single versus double internal mammary artery grafting, and by intention to treat, there was no significant mortality benefit at 10 years, which was the primary endpoint. However, this trial was importantly flawed. About 40% of patients received a different treatment strategy than intended, 40%. 14% of patients assigned to double ITA grafting actually received a single ITA, while 4% assigned to a single ITA actually got a double ITA. And 22% of patients who received a single ITA also received a second arterial graft in the form of a radial artery. So if we now look at an as-treated post-hoc study or analysis within the ART trial, we see that single arterial grafting compared to multiple arterial grafting had a striking survival benefit over 10 years, about a 20% mortality benefit. Several years ago, I looked at Emory University at about 15,000 primary coronary bypass operations, and we categorized those patients as either having diabetes or not having diabetes and receiving single versus double ITA. We carefully risk adjusted the comparisons and demonstrated that patients who survived longest were those who had no diabetes and received 2 ITA grafts. The second best surviving group was patients who had diabetes and received 2 ITA grafts. They outlived patients who did not have diabetes but were only given a single ITA graft at the time of coronary bypass. The worst survival was in patients with diabetes who received a single ITA graft. So this is a remarkable study. It demonstrates that the provision of 2 ITA grafts at the time of coronary bypass grafting is more important for long-term survival than the presence or absence of diabetes. Many surgeons don't use double ITA grafting because they're concerned about deep sternal wound infection, but that risk can be mitigated with a skeletonized harvest of the internal mammary artery. And this is how we do that, using the harmonic scalpel. That's important because it turns out that the large majority of surgeons, even in the ART trial, had difficulty with harvesting double ITA grafting. The conversion rate from beta to theta was 14%, but that ranged between 0 and 100% from individual surgeons and between 0 and 50% for centers. Now, there's another way to provide a second arterial graft, and that, of course, is the radial artery. Mario Gaudino and others took a patient-level data set from 6 individual RTA, randomized controlled trials, and did a patient-level meta-analysis. With this large population of patients, we were able to demonstrate that death, myocardial infarction, and revascularization was less common in patients who received a radial artery graft in addition to their ITA versus just vein grafts in addition to ITA. And this had to do with a lower incidence of graft failure in the radial artery group, thus a lower incidence of repeat revascularization in the radial artery group. And this, I think, contributed to the recent European guidelines advocating a second arterial graft and the use of the radial artery graft, beta grafting also to be considered, and skeletonized ITA harvest is recommended to reduce risk of sternal wound complications. I would argue that a second arterial graft should be recognized as a quality metric, and that will help drive improvement in coronary bypass grafting, because we see that nationally, in the United States at least, utilization of double ITA grafting is at a paltry 5% or 6% level, and use of a radial artery is similarly low. So something on the order of 95% of patients do not receive a radial artery graft and do not receive double ITA grafting. Now, documentation of graft patency is important prior to leaving the operating room. This is the request trial that many of us participated in. It was a prospective observational study of 1,000 patients having isolated primary coronary bypass surgery at 7 sites in Europe and North America. We demonstrated that about a quarter of patients would have their surgical strategy altered or improved or individualized by use of intraoperative ultrasound technologies. Some of those had to do with the choice of a site on the aorta for proximal anastomosis. Some had to do with choosing the site on the coronary target for the distal anastomosis, and some had to do with revising anastomosis themselves when flow was inadequate. This has led to the European guidelines again recommending quality control in the operating room. I have to say that I think it is bizarre that coronary bypass surgery is the only major vascular surgical procedure that does not include a completion angiogram or other routine means of confirming patency. Patients come to the operating room for coronary bypass, and 6 to 8% of them have atrial fibrillation at the time of surgery, but only a minority of those patients receive ablation for their AFib at the time of their coronary bypass. This study in the European Journal demonstrates that mortality is improved with the addition of concomitant AFib ablation at the time of coronary bypass surgery for patients who have AFib. This is another study looking at a large Medicare data set. 9.6% of patients had preoperative atrial fibrillation, but only a third of those received ablation. And the patients who received ablation had a lower rate of stroke or embolization or mortality past 2 years of follow-up. And this helped to ensconce within our guidelines a recommendation for surgical ablation of AFib at the time of isolated coronary bypass grafting. Now, medical management of the coronary bypass patient is also woefully inadequate. Dual antiplatelet therapy has been demonstrated to improve graft patency, reduce MACE, and perhaps benefit most of those patients who are having off-pump bypass, since those patients do not have the coagulopathy associated with the heart-lung machine. DAPT is shown to reduce all-cause mortality in Cabg patients and not to increase bleeding risk. In this British Medical Journal paper of 20 randomized controlled trials, about 5,000 patients, they reported moderate certainty evidence that supported the use of DAPT to reduce vein graft failure compared to aspirin alone. And in this Swede heart trial, we note that other medications are also important for coronary bypass patients. In almost 30,000 patients, a careful study demonstrating that optimal medical therapy is crucial for patients after coronary bypass. The use of secondary prevention medications declined over time after surgery, and that decline was associated with increasing mortality risk. Thus, we recommend medical therapy and lifestyle changes as Class 1 recommendations in the guidelines. Now, Michael Mack and David Tagret published this very interesting editorial in the JTCVS a couple of years ago, arguing that coronary vascularization should be a subspecialty within cardiac surgery. They note that in orthopedics, there are a dozen subspecialties, and within thoracic surgery, about 10 as well. But coronary surgery is not one of them. We have standards defining a heart valve center for the European Society of Cardiology, and a writing group, transatlantic writing group, proposing to optimize care for patients with valvular heart disease, but not with coronary artery disease. And I ask you, which is the most technically challenging operation? An aortic valve replacement, a Bentall, a transcatheter valve replacement, a mitral replacement, a mitral repair, a heart transplant or lung transplant, a vasolobectomy or an esophagectomy, or a no aortic touch all arterial off-pump bypass? Ladies and gentlemen, I've done all of these operations numerous times, and I can tell you the last one is technically more demanding than the others. So a dedicated coronary artery bypass surgeon would be someone who's genuinely committed to routinely performing Cabg according to evidence-based practice and is trained in the state of the art, perhaps through an advanced coronary surgery fellowship, would identify him or herself as a coronary specialist, adhere to guidelines, participate in heart team approach, public reporting and clinical research, and also in training and education of our next generation. We have an advanced coronary surgery fellowship here at Mount Sinai Morningside Hospital that offers a comprehensive curriculum over 1 to 2 years and is intended for graduates of cardiac surgical training who want to focus on their career on surgical revascularization. And the reason for all of that is because the persistent gaps remain between evidence-based practice and current common practice. That is the rationale for specialization. Cabg is by far the most technically demanding procedure that we commonly perform. It requires dedicated training and practice to achieve optimal outcomes. I reject the notion that Cabg should be relegated to a single chapter in a cardiothoracic surgical textbook or a single session at our annual meetings. This is a textbook published last month by Oxford University Press, edited by myself and David Tagret, entirely devoted to every nuance of surgical coronary vascularization with over 100 authors globally. We also developed a 2.5-day meeting called the International Coronary Congress, focused on basic and advanced techniques in surgical coronary vascularization. This is a collaboration between leading coronary surgeons from around the world to elevate the quality of surgical revascularization of the coronary arteries globally. That is the raison d'etre, the reason for being of the International Coronary Congress, to bridge the gap between best evidence and common practice in Cabg. I invite all of you to attend the International Coronary Congress in New York in person in December of this year. I want to thank the organizers again for the consummate privilege and deep honor of delivering the Tudor Edwards Lecture 2021. Thank you.
Thank you, John. That was an excellent lecture, and I can say that I do not think there would be any other surgeon who would have done as much to produce evidence for in the field of coronary artery surgery and then to push for that evidence to be implemented. Can I ask you a question? The incidence of use of bilateral mammary arteries still is so low, especially in the Western world. In Japan or in the Eastern countries, for example, the use is much higher. What could be done, or what single thing could perhaps make the biggest difference in more surgeons using bilateral mammary arteries?
I think the action that is needed is that our societies need to recognize bilateral ITA grafting as a quality metric. I mean, for goodness sakes, we all chased our tails like mad to be sure that we had given beta blockers pre and post-op to patients, and then after a few years of study, figured out it didn't really make much of a difference in survival. But we know from decades of trials that double ITA grafting is associated with better survival, and yet that is not a quality metric. There are reasons for that, especially in America. We have an obese diabetic population. When I started my practice in 1996, about 15% of patients having coronary surgery were diabetic. Now it's about 60%. I mean, the majority of patients having coronary surgery are diabetic. It may, in fact, exceed 60%. And with BMIs in the high 30s and 40s, there's fear of deep sternal wound infection. The Center for Medicare and Medicaid Services, the primary funder, the government funder of cardiac surgery in the elderly in America, has in its infinite wisdom decided that they would have a list of never events. One should never operate on the wrong side, operate on the wrong breast, or operate on the wrong eye, or fix the wrong hip. But they also decided that never events should include a deep sternal wound infection after cardiac surgery. And never events are important because the surgeon who commits them is automatically vilified, and the hospital in which it occurs is not reimbursed for the cost of fixing the problem. So now that heart surgeons in America are, for the most part, employed by hospitals or hospital systems, if they have a deep sternal wound infection, the cost of that therapy is borne by their employer, the hospital. And that makes them very unpopular with the hospital management. So the consequences of a deep sternal wound infection for the surgical practitioner are immediate and harsh, while the benefit of double ITA grafting is delayed, not felt by the surgeon or the hospital administrator, but rather enjoyed by the patient a decade or two later. And this disconnect between incentives and quality is I think what is driving the avoidance of double ITA grafting.
Yes.
Good. Dr. Puskas, can I ask you, what in your opinion are some of the barriers which are precluding the adoption of coronary artery surgery as a subspecialization?
You know, it struck me as odd, for instance, that there was so much interest in advanced mitral surgery, and that became a subspecialty so early. I think that was driven by mitral enthusiasts who globally were very excited about their own craft and had a skill set that was not common. I think they were able to encourage the redistribution of mitral cases by referral from surgeon to surgeon or within departments, because mitral surgery didn't actually make up a very important part of the bread and butter of most cardiac surgeons. The honest truth is that in America, the average heart surgeon does 4 mitral operations per year. So giving up those 4 in the name of quality to a colleague who will focus on mitral surgery, it's not a big sacrifice for the individual surgeon, and there are data to suggest that we do a better job when we do an activity frequently. On the other hand, coronary surgery is the bread and butter of most cardiac surgeons, and most people are not willing to give up their livelihood, even if they don't want to advance or change the treatment that they provide to the coronary surgical patient, and they want to keep doing it the same way they were taught in the 1990s, and that way is the same way that teacher was taught in the 1970s. You know, we still don't want to give it up. So I would argue that we need to evolve. I don't think we're going to get patients to simply not go to most surgeons. I think most surgeons will not participate in that idea. But I do think we need to have specialty training in it.
Shahzad, are there any questions from the audience since you're looking at the Slido? Can I ask you, John, while we get other questions, what about flow measurements? Flow measurements have been there for a long time now, but it's still not routine practice. In fact, in our hospital, we just got the latest Medistim device just last week. We had an old one before that. What do you feel about that not being used routinely?
You know, it's not reimbursed. You don't get paid more for using it. It does add a small cost to the budget for the case. But in my mind, those are not adequate reasons for failing to do it. I mean, I think that whenever we have an opportunity to be more sure that our graft is patent, we should take that opportunity. This Medistim device is the best available now. It is imperfect. I have worked with others along with the engineers at Medistim to try to make it better, and they do have a new version that's going to come out later this year with much more user-friendly software and for that matter, more ergonomic hardware. It's not a perfect tool, but it is the only easily used intraoperative tool we have to confirm graft patency. Again, there is no vascular surgeon alive that would perform a revascularization of the leg without a completion angiogram. And that completion angiogram is reimbursed. It's one of the billing items in their procedure. The same should be true about revascularizing the heart muscle, as is true about revascularizing the gastrocnemius muscle.
We have a question for Dr. Puskas. It's from John Donovan, who says the use of vancomycin has reduced our sternal wound complication rates to almost 0. Would you care to comment?
I am a huge believer in vancomycin paste. We put it in every single patient in the bone marrow. You mix a vial or 2 of the powder with just a cc or 2 of plasmolite or saline. Knead it between your fingers until it's really stiff. You don't want to put it on like it's heavy cream. You want to put it on like it's really stiff, tough stuff, semi-dried fiberglass resin, and end up with an occlusive strip. We put it on at the beginning of the case to minimize shed blood from the bone marrow, and then we redo that at the end of the case before pulling the sternal wires shut. And it has, I think, been an important contributor to an exceedingly low risk of deep sternal wound infection, despite the fact that the large majority of my patients are diabetic and obese, and the large majority have double ITA grafting. I think it is a key feature. And I'll also say that it doesn't promote vancomycin toxicity or renal failure. We have actually measured the vancomycin levels in the blood and in the chest tube drainage. The blood and the chest tube drainage is, the vancomycin in the chest tube drainage is astronomically high. We got a, frantic phone call from the lab that my patient had a vanco level of 2,000, when 20 in our lab is the upper limit of normal therapy. But that was from the chest tube drainage. The same patient's blood had a barely therapeutic level of vancomycin, and that quickly passed in a day or so. So it's not a toxic systemic absorption. It is an effective hemostatic agent, and it seems to be an effective local antibiotic therapy.
Thank you.
Okay, John. Me personally, I'm looking forward to the book State of the Art Surgical Coronary Revascularization. And I must say thank you, John, for this excellent lecture, and thank you for all the work you've done on coronary artery bypass graft surgery over the last few decades. And
thank you all. It's been a real honor to deliver the Tudor Edwards lecture and to participate in the SCTS meeting this year.
Okay.
Thank you very much.
Thank you, John, and thank you, Shahzad, and thank you, audience, for your attention. I think we'll bring the meeting to a close now.
Thank you. Bye-bye all.